I would like to introduce Professor Ron Allison, Medical Director, 21st Century Oncology, Greenville, United States. Thank you, Professor.
So thank you again for the honor of being able to talk to everybody. And today we'll take a look at photosensitizers in PDT. So it's arbitrary to just look at the photosensitizer because we know PDT is really very elegant and very beautiful, but it has a lot of components. What photosensitizers are, or what they do, is they transfer light energy. They probably do a lot more than that, but classically you think of a successful photosensitizer as something that creates a type 2 photochemical reaction, and we'll talk a little bit about that in a moment. But these photosensitizers are all over the place. Many plants produce photosensitizing agents. You might have brushed against something in the bush, and then you get a burn from the sun because a lot of plants protect themselves with photosensitizers. And blood is an excellent photosensitizer. So is the dye that we usually use in ink for pens. So there are a number of items that are naturally available that can behave as photosensitizers, and apparently can create almost unlimited quantities in the laboratory of photosensitizers with very interesting characteristics. So while there may be thousands and thousands of these agents around there, maybe perhaps 10 or 15 have been pursued in clinical trials on patients, and of these 10 to 15 that have pursued clinical trials, depending where you are in the world, you may only have 1, 2, or 3 available to you. And there are probably about 5 or 6 of these agents that are commercially available. But again, depending on where you live, you may or may not be able to purchase them to treat patients. So what's really happening with the photosensitizer is it's the type 2 reaction, which is the photodynamic reaction, the PDR. And you need light of appropriate wavelength and energy to activate that photosensitizer, and that photosensitizer, once in its active state, interacts with oxygen, which is common in many tissues, but not so common in tumors because tumors are hypoxic. So it's an interesting irony there that you need oxygen to have a good photodynamic reaction, but tumors might not have oxygen. We'll talk about that too. So what's really happening is you have an inert state of the photosensitizer, and that's sometimes called the single or singlet state. And then if you bring in light, and it has to be the correct light, you get to the triplet state. And what's apparently happening is the light is interacting with electrons, and it brings an electron up into an illegal and illicit spin. So you have 3 electrons, and the third one is odd out. So it's not like that TV show Three's Company. It's bad. So that third electron gets shot out and usually interacts with oxygen, but it can interact with other things. If the light is taken away, the active photosensitizer can go back to its inert state, and apparently this flip-flop between active and inactive photosensitizer can happen quite a bit, even during a treatment. So what is an active photosensitizer really doing? Well, it can do a lot of things, but for photodynamic therapy, we really just think of this type 2 reaction, and maybe that's small-minded of us, but the development of photosensitizers has been to more and more type 2 reactions. There's a type 1 reaction and perhaps a type 3 reaction. All of these can be toxic. What's interesting about the type 3 reaction is that you don't need oxygen for that. So if you've got a hypoxic tumor, it might be interesting to develop photosensitizers that seem to go for direct toxicity. Of course, the photosensitizer can lose energy in several fashions, and if there's oxygen around, it can fluoresce, and that has a lot of clinical ramifications, as we'll talk about in a few minutes. So the photosensitizer, when it's active, can do many things, and ideally what it'll do for us in PDT is create that type 2 photochemical reaction, generate that singlet oxygen, which is very, very toxic. So once again, just to shove it down your throat, the photodynamic reaction is considered a type 2 reaction. It's relatively long-lived, supposedly. You're illuminating patients for 5, 10, 15, 20 minutes, so there's a long time for that singlet oxygen to be produced. And the downstream activity of that singlet oxygen, it's very lethal to anything that it interacts with. So it generally will either rapidly destroy a cell or a vascular membrane by necrosis, or it can, in a more programmed fashion, shut everything down through apoptosis. Sometimes another particle will come in and create phagocytosis. But the type 2 reaction is what successful PDT is all about. So how do you design these photosensitizers? Well, again, classically, it was to create that type 2 reaction. And maybe that's not the right way of doing things. Perhaps it's better to create photosensitizers that can target certain tissues or certain parts of tissues. Optimal photosensitizers activate when you turn the light on. And there's a thing called dark toxicity. Oh, camera shot. Okay, thank you. One more? Okay. Thank you. So there's a thing called dark toxicity where the photosensitizer may actually be toxic, and some very successful photosensitizers apparently are toxic in the dark. So you have to be very careful about that. So you really want it to only be toxic when you turn the light on. Another thing about photosensitizers designing is that you should be able to have some sort of informal or formal means of controlling them, and that would call dosimetry. So you're familiar with radiation. Radiation, the interaction of radiation and matter is fairly well understood. So if you deliver a treatment to a patient with radiation, you can predict the outcome of that individual to a high degree because you understand the interactions of radiation. The interactions of light for dosimetry and PDT are far less well understood, although great advances are being made. But the reality is you want a drug that you can control to a certain degree. Fluorescence is a very interesting aspect of photosensitizers. The more active you are on the photodynamic reaction, the less the photosensitizer will fluoresce. It seems there's a reciprocity between fluorescence and photodynamic activity. But having the ability to fluoresce is very, very important in the clinic, and it's underutilized, and we'll come back again on that. But the most important part of a photosensitizer is to be able to give it to the patient who needs it. So again, there are tremendous, excellent, wonderful photosensitizers around, but you just cannot get them into a patient because they're not available, which is sad. So why does a photosensitizer target a tissue? Well, nobody really understands that, but there's quite a bit of work on it. It's interesting that when you have a photosensitizer and you bring it into your circulation, generally either orally or injection, it breaks down into nanoparticles. So nanoparticles are already part of the photosensitizer family. It's nothing new, although you can create nanoparticles, but things like Photofrin apparently behave as nanoparticle-sized material, and nanoparticles, for whatever reason, seem to be uptake to a certain degree by receptors on cells, and the LDL and VLDL, which are lipoprotein receptors. So it seems to me that the photosensitizers that are successful, that can circulate by themselves, they seem to be recognized as some sort of food source for these tumors. So these tumors have high receptor levels. The photosensitizer seems to behave or is bound to these receptors, and that's how it gets in. So it also concentrates wherever the receptors are upregulated. So not only do tumor cells have it, but the vasculature that those tumor cells seem to create, the neovasculature, also has receptors. So you get a lot of the drug in the tumor region and in the vessels that feed it. So it's a fairly interesting combination. The other aspect is that supposedly tumor regions don't clear things as well. So that's why they can be hypoxic and acidic. So leaky neovasculature doesn't clear the photosensitizer as well, and the normal tissue surrounding it, because it has good blood supply, clears things. So there's probably a combination, and every photosensitizer likely has a very, very specific way it gets to where it's going to go. Some of the really very good photosensitizers cannot be injected directly because they have to have a certain amount of hydrophilicity and lipophilicity to circulate. So some of the successful photosensitizers are bound to carriers that bring them. So it's a complex issue to understand targeting. And then one of the things that we do to help the photosensitizer is we put the light in the correct spot. So in other words, it's a 1-2 punch. The photosensitizer is intelligent enough to get to where it's supposed to go, and then the clinician and scientists trying to get the light source are intelligent enough to put the light in the right spot. So it's a 1-2 punch that way. Every photosensitizer has its own activation wavelength, and many have several. because of the structure. It's quite interesting. There's a desire to try to get photosensitizers that activate at higher wavelengths in the red and infrared region, and we'll talk about why that may or may not be intelligent design, but that's the design that's used these days. So if you have a clinic and you think you're going to do 6 different photosensitizers, there's a very good chance that you'll have to have 6 different light sources. Each of these light sources are fairly expensive, unless you're an ingenious person and has like a knob that will give you different wavelengths. That would be a big breakthrough, but commercially, every photosensitizer has come with its own light source. It's in a very expensive combination, and if you have unlimited funds or you can design your own family of light sources, it's excellent to have these all available, but usually a place just has one light source and one drug that they're familiar with. But it's very important to understand that while they're all behaving as photosensitizers, each different photosensitizer behaves differently, and we'll talk about that as well. So we had a beautiful lecture with a lot of fantastic mechanisms and equations. I don't have any of that. I'm sorry about that, but you can refer right back to the previous lecture. But there's an optical window in the body, and there was a beautiful slide that I almost misunderstood, but got close this time to understanding. So you have competition to the light. So the photosensitizer, you want that light to go to the photosensitizer, but your body takes the light and absorbs it with blood, and water competes. So there's a small window for light to actually transfer in the body to activate the photosensitizer. So yes, you could develop a photosensitizer that activates at very, very long wavelengths for deep tissue penetration, but your body won't let that activate because it'll preferentially interfere with the light. So the clinical spectrum is really quite limited to between blue light and red light. You could have much better photosensitizers, but your body won't let them activate. So what are the light sources? Well, again, any light source that gives you the appropriate wavelength and energy. So it can be sunlight, that's very potent, very inexpensive, hard to control, but lasers and LEDs are very precise. It gives you a very, very good ability to energize your photosensitizer. I think, again, that in a place like Brazil, having the wonderful sun that you do for most of the year, that's a very inexpensive way of doing treatment for patients, but you have to have a good way of measuring how much light is going on. So again, the future will have all these light sheets that these are external, but you can imagine you could implant the light sheet into a tumor, you could miniaturize it, you could do all sorts of things. Most of the treatments are usually something like this or a little bit smaller these days. It gives you the light source on a fiber optic that you can put to wherever the tumor needs to go, and it gives you the false security of giving you the time that you think is appropriate for treatment, even though that has absolutely nothing to do with what's being delivered to the tumor. So these are organic LEDs. I think one day these organic LEDs will be miniaturized and dissolve, and you're just going to put it right into a tumor. It's going to turn itself on and off several times during a treatment, and then the body's going to absorb it, and it's going to be a phenomenal future for PDT if it gets that way. What we like to think about in terms of photosensitizers is we like to think about a way that we can control them so that you can ablate the tumor and leave normal tissue around. So as the previous lecture showed, the ability to understand the interaction of drug and light and tissue, it's really quite complex. So our simpleton idea is to ablate the lesion and preserve the tissue. So ideally what would happen is that you just have enough drug into the tumor to destroy the tumor, but not enough drug in the normal tissues that even if you gave a lot of light there, you wouldn't overdose the normal tissues and injure them. So the dosimetry that we use now is an applied drug dose. The applied drug dose has very little to do with what is in the tumor. We give a certain milligram per kilogram dose of a drug, and we make these gigantic assumptions that the drug is going to where it's supposed to go in the appropriate concentration. It would be much more elegant to actually measure what the drug was doing in the tumor, and that's what the future of PDT, and we'll talk about that too. But today, you just give, let's say, Photofrin 2 milligrams per kilogram, you wait a specific amount of time, you turn the light on for a specific amount of time, and that's the whole treatment. And some patients will have wonderful outcomes, other patients will have less wonderful outcomes. Again, why? Because you don't really know what the drug dose is, and you also only know what the light dose is from the light source. You don't really measure the light at the tumor. So these are nasty little shortcomings of PDT. What's also interesting is the drug-to-light interval. The same drug used at a short drug-to-light interval. In other words, if you inject the drug and then turn the light on within an hour, that drug will behave differently than if you waited 6 or 12 or 24 or 48 hours. The drug is generally vascular in the immediate period after injection or oral intake, so the blood supply is controlling where that drug is. But as you give it time, it concentrates in the tumor, apparently, and leaves the vascular supply. So if you were to use Photofrin on the same day as injection, you'd get a very strong vascular treatment. If you wait about 2 days, you get a more specific tumor treatment. And then if you wait 5 days, you get an even more specific tumor treatment. So you can vary the drug light interval, but hardly anybody does that. So for a rule of thumb, unless you have got a good dosimetry system, you want to remember that the photosensitizer concentrates in the tumor and it clears normal tissue. And if you just use enough drug to concentrate in the tumor but leave normal tissue, you should get a fabulous response. So I don't know how well this projects, but if you think about it this way, if you use a lot of drug, a lot of drug will go into normal tissue, more drug will go into tumor, but you're illuminating both normal tissue and tumor because you really don't know where one starts and the other ends. So you'll get a very, very intense photodynamic reaction in the tumor, but because you've flooded all the tissue with normal tissue with photosensitizer, you get a stiff reaction there. So you get a reaction, no doubt about it, but not the kind of reaction that you really want. On the other hand, if you use a lower drug concentration, again, a lower drug concentration, the tumor is smarter than we are, it concentrates that photosensitizer, but the normal tissue doesn't really want the photosensitizer, so you get a lot less photosensitizer. Again, you're illuminating the areas roughly equivalently because you don't know where the tumor starts and the normal tissue ends, but because you're using the intelligence of the drug, you can get a more selective reaction. I have a few photos to try to show you that clinically. Again, one of the other aspects that's underutilized in these photosensitizers is that most of them will fluoresce. And how they fluoresce and what you can do with that is quite interesting because if you think about it, if you're using just enough drug to concentrate in the tumor and leave the normal tissue kind of alone, if you were to fluoresce that region, you would probably get a very good idea where the tumor is and where the tumor ends. Maybe not perfect, but probably a lot better than your eye does by itself. So you can use fluorescence to demarcate tumor borders. You can use fluorescence to help you detect tumors. Ideally, once you use up the drug and kill the tumor off, it won't fluoresce anymore. And as was spoken about quite elegantly previously, you might one day actually be able to just use fluorescence to biopsy these lesions optically and save a patient the scare of having to wait for a physical biopsy. So when you go on in your career as a PDT, try to remember to do more fluorescence. It'll move the field forward. If you look at photosensitizers, people try to always classify things, and it's hard to actually classify them for any clinical utility. So it seems like you say there's a first generation, and then there's a second generation and a third generation photosensitizer, and that implies to you that the second and third generation are better than the first. But the reality is the first generation photosensitizer, which we consider Photofrin, still outperforms even the newer agents. So to say first, second, third generation doesn't work out too well. Some people like to do it by structure or purity. Photofrin is not a pure drug, so it's interesting today if you were to try to get Photofrin approved, because it's made up of so many different components, most agencies would not approve it. So Photofrin was developed at a time where that was not as critical as it is today. So purity is good for administration and agencies that do approval, but in terms of actually doing treatment, it doesn't matter because Photofrin is one of the most impure substances, yet it's the most fantastic of all the drugs at this point. You could create a scheme like vascular targeted PDT or cellular targeted PDT. You could try to classify that, but again, if you take the same drug and you do a different drug light interval, it might be behaving as a vascular agent just a few hours after you inject it, and as a cellular agent 24 or 48 hours. So all of these ideas of classification are of limit. Structure might be an interesting way to do it. You could use one application of that as let's say porphyrins, which is purines, chlorines, all sorts of things that we're using today. You could make another as dyes. You could make another as buckyballs. You can make another as nanoparticles. So structure might be a way to understand photosensitizer classifications. But again, in the clinic, you just want something that really works well and doesn't cause a lot of grief to the patient. So what is it that we use? Well, despite all this nonsense about not knowing what we're doing, you can still get really, really good results in the clinic. So the first photosensitizer was Photofrin, and it's, again, to me, it's the old reliable. It always works. It works so well that many companies around the world produce knockoffs, and even though they're not identical, they still work very, very similarly. And what they do is they give you a very good ablation of tumor in a fairly pain-free therapy. So what does that mean? It means you could use it any place, any time, as an outpatient, in the operating room, wherever you have in the clinic, and you get a very, very good response, and the patient's not screaming and running out the door after 30 seconds, which is what happens in a lot of the newer and better photosensitizers. Here's the structure. This is very similar to blood. There's no iron in there. And to have clinical success with Photofrin, you have to have this odd combination of monomers, dimers, and oligomers. If you try to separate it out, the drug doesn't work. Nobody really understands why you need all these things and in what concentration, but the reality is the more pure you make Photofrin, the less well it works. The standard treatment is 2 milligrams per kilogram. You wait 48 hours. So a lot of times you'll inject the patient on Monday, you treat them on Wednesday. It uses red light, not the optimal wavelength, but a good wavelength for tissue penetration. The problem with Photofrin, again, in the red wavelength, it takes a long time to generate enough singlet oxygen to do a good treatment. So 20 minutes might not be too bad, but if you've got 5, 10, 15, or 20 lesions to treat, hopefully you have 5, 10, or 15 lasers to use. Otherwise, you're going to be there all day. The basic drawback to Photofrin is about 6 weeks of photosensitivity. It's really serious photosensitivity in the sense that you cannot go out in direct sunlight. So from dawn to dusk, if you're going outside, even for 30 seconds, you are just have to be covered up like a mummy. And it's a very big drawback. But if you consider the alternative, let's say losing your voice box or losing a limb or losing an organ, staying out of the sun for 6 weeks, no big deal. So Photofrin has been used in pretty much every tumor, and it's been successful in pretty much every tumor. As I spoke to you yesterday, a lot of treatment to the skin by Photofrin, it's tremendous because it doesn't matter how thick the lesion is, it still works. The problem with some of the topical creams is anything that's more than 1 millimeter or 2 in depth, it doesn't work too well because it doesn't penetrate enough. But anything that this has been tried on, Photofrin has worked. The problem is if you use a high drug dose and a high light dose, you're overdosing normal tissue and you'll get fibrosis. If you use a lower drug dose or a lower light dose, you can get pretty good work. 2 milligrams per kilogram, why was that chosen? Because in the good old days, when you went to a regulatory agency, you wanted to show that it could do the treatment. So 2 milligrams per kilogram, very, very rare would that not ablate a tumor. But again, 2 milligrams per kilogram goes into normal tissues too, and that's why you have a lot of normal tissue slough and reaction. Interestingly enough, the normal tissue will heal quite nicely, but if you use a lower dose like 0.8 milligrams or 1.2 milligrams per kilogram, which is an order of magnitude lower, you can get a lot more selectivity. You could also activate it at blue light or green light, so you don't necessarily have to use red light, and a lot of this can be done with the clinic if you think about it. So every case is a little bit different. You should optimize the treatment parameters and the light sources for each patient. Again, just to show the singlet oxygen production is really quite low, and since at the time that new photosensitizers were coming in, the thought was do more activity at these higher wavelengths because that's what you really wanted. It's not the most elegant way of doing things because if you think about it, at a higher wavelength, you have more photons of energy of light going to distance, but you don't know really where it's going. So if you have an elegant way of doing things, you'd want more control. So in the blue range, where the light doesn't penetrate too much, you can control where you're treating. In the red range, where those photons of light are going very, very deep, you can get into a lot of trouble. ALA came about shortly after Photofrin. It's a prodrug, And if you are an unfortunate person, you might have an inherited problem with your heme synthesis. And these are the family of diseases called porphyrias. And if you're in that family, that means you're inadvertently producing photosensitizing agents. And as was mentioned yesterday, the idea of Dracula came about probably because of these porphyrias, because what's happening is you don't have the appropriate synthesizing of heme in your body. You get a buildup, for example, of protoporphyrin 9, which is a very potent photosensitizer. If you go out in the sun, that protoporphyrin 9 is all in your skin and starts to burn your skin. If you remember, light interacts with matter in interesting ways, so pointy areas like the tip of your ear or your nose will get a lot more sun exposure and reflectance. So if you can imagine, you'd burn the tip of your ears and your nose. And if you think about vampires, they have very pointy noses and pointy ears. So it probably really was true about that. And the other aspect is because you're screwing up your heme synthesis, you really have usually a lack of iron. So you drink people's blood to get iron. So it kind of makes sense in a weird sort of way. But see, Mother Nature always thinks for you. You just follow what they do. And you could take ALA, aminolevulic acid, and you could modify it with different attaching agents and create things that behave slightly differently. So what happens is with methylation and Metvix, you might get a little bit deeper penetration. With hexylation, you get much more fluorescence. So you can modify the ALA, and I think the future of cutaneous PDT, and a lot of PDT will be on these topical and oral agents like ALA. So the problem with the topical penetration of ALA is it's only 2 millimeters. You really cannot treat deeper than that. If you do, you just burn off the top of the tumor and you let the bottom of the tumor grow. So if you've got something that's deeper than a millimeter or two, you have to repeat the ALA treatment 4 or 5 times. If you do the drug orally or intravenously, you'll have about 3 days where you can do treatment, but you'll also have cutaneous photosensitivity. The problem with ALA is the way we do it today, probably we're doing too much illumination. It's very, very painful. So those of you guys working with ALA, you should modify the light dose, make it a little bit more prolonged, maybe less intense, and write up your results, because I think you could probably get a good treatment with this without the pain just by modifying some of the illumination principles. It's wonderful in the skin. There have been dozens and dozens of randomized trials, which is important, and PDT to the skin for the right lesion, not only does it get rid of the tumor, but it doesn't leave a scar. So in comparison to what the standard of care is for the skin, which might be surgery or freezing or all sorts of things, PDT to the skin, again, excellent cosmesis. ALA has also been used in the brain for fluorescence, and in the esophagus, they've used green light, and apparently quite successful. Based on some of the shortcomings of these drugs, a newer drug called Phoscan, temporphyrin, it's a very popular drug. It's a plant-based drug. It's a chlorine. You use a tiny amount. In fact, I think at this point, 0.1 milligrams per kilogram, which is really a small amount, that's too high a dose. And 20 joules, which is, again, very little light, that's too high a dose too. And what's very interesting is that for the first day or two after you get that drug in you, if you were sitting in this room, you'd get a sunburn, and it could be severe. So for the first day, when you use Phoscan at the standard drug dose and light dose, you've got to be in a dark room with less than a 60-watt bulb, otherwise you're going to burn up. And you have still 2 weeks of photosensitivity. The problem with having something like Phoscan, which is so active, is that it only takes about a minute or 2 minutes to do a treatment. But you know, if the patient took a deep breath and held it for a second, as some patients do, in that 10 seconds, there'd be enough light interaction for the Phoscan to burn a hole in that area. So here's something, a drug that was designed to be so active compared to Photofrin, but in Photofrin, it takes a long time of illumination, so if you miss the target, the patient moves. With Photofrin, you have time to correct it. With Phoscan, somebody moves a little bit, or you don't block off reflected light, you're going to create a fistula, and that's how potent it is. But despite the fact that it's very, very hard to control, it's a fantastic drug with a little bit of practice, outstanding results in the skin and head and neck. but so far it's been a little bit too morbid in other areas, so dosimetry really, really does matter. Vertiporphyrin we talked about a little bit yesterday. This is a porphyrin derivative that's very, very interesting in the sense that it was the first really successful worldwide drug because somebody figured out that this was a vascular acting agent and looked for a disease that was worldwide and common, which is macular degeneration. So wet macular degeneration, you have these leaky blood vessels that eventually cause you to go blind. So somebody said, hey, I've got a drug that destroys these leaky blood vessels. I've got a disease that causes a lot of blindness around the world. They put 2 and 2 together, and they created beautiful trials that were made available worldwide. So here's a drug that got worldwide acceptance very rapidly, was a standard of care for many years, but as medicine progresses or changes, now there's anti-neovasculature agents that can be injected either in the eye or in the skin that stop these blood vessels. So this ophthalmologic indication, which was worldwide, and it grew like that, went downhill just like that. So that's the scary part about anything that you're doing. You might be replaced. You might be obsolete anytime. Another drug that's available now is called MACE. It's a chlorine. It has a slightly longer wavelength of penetration, and it has a shorter photosensitivity. But what's interesting about MACE, which goes by many, many different names, is about 4 to 6 hours after you infuse it, you can treat a person. So it's a vascular acting agent, and it works wonderfully in the lung and also in the head and neck. So this is something that is interesting because you can see the patient in the morning and treat them in the morning. You can have them come back the next day, come back the next day. So this is a very, very versatile agent. So MACE is probably one of the drugs that will continue to grow worldwide. There are dyes. These dyes are some of the original photosensitizing agents, but they've never really shown themselves to be wonderful in clinical trials. So yes, they do work, and they have interesting characteristics because you can apply these intravenously, orally, or topically, but so far there haven't been too many trials to show them to work in real life. An interesting photosensitizer was discovered from bacteria. So bacteria have these chlorine derivatives too, and what you'll notice is it can really treat to a very, very deep penetration of light. And most interesting is you actually infuse this drug, and while it's infusing, you turn the light on. That's how rapid it's circulating. So you treat a patient within an hour of starting treatment. And what's very, very interesting too is whoever decided that they wanted this drug to be worldwide available looked at prostate cancer because it's such a common disease. But unfortunately, they hadn't figured out some of the dosimetry issues. And even though this was potentially very spectacular, in the early trials, either there was too much light or too much drug, because even in the first 10 patients, there were fistulas between the prostate and the rectum and the prostate and the bladder. And you'd have to treat about 100,000 people with surgery or radiation before you saw that kind of side effects. So even though it was a fantastic idea and probably a phenomenal treatment, just because of that lack of appropriate dosimetry, it held this back, and it's held it back to this day. So it's unfortunate. All good ideas must be tested appropriately. The Photofrins, what's interesting about those guys is that right now, if you were to get an MRI scan, you would get a Photofrin as a contrast agent. And those same agents have the ability to do PDT. So here's something that's probably ripe for the future of PDT. Not only does it help you with diagnosis, but if you wanted to, you could actually treat a patient. So I would think that some of these agents in the near future will not only be used for diagnosis, but for treatment as well. And then there's this last drug, which is a shame because it's a fantastic drug, but it's sat on the shelf and its patent is pretty much over. So even though this is a drug that probably could have replaced Photofrin because it treats very similarly to Photofrin, it only has several days of photosensitivity. And there has a whole family of drug trials and light trials showing that this works wonderfully, but the drug was bounced around from company to company for so long that the patent actually expired, and most likely this wonderful drug will never be commercialized. So what are we going to do in the future? Well, probably a lot of intelligent people here are thinking, well, these photosensitizers can be used for multiple things. They can be conjugated for imaging as radiation sensitizers to help chemotherapy get to where it's supposed to be. Photosensitizers are very, very good at targeting, so you could use the photosensitizer to bring something else in. Perhaps you could conjugate a photosensitizer with a light source so that you wouldn't really have to worry about things traveling a distance in the body. So the future is pretty strong to take a photosensitizer that already exists and try to exploit its other characteristics, which is very, very rarely done these days. And it's a shame because the drugs are there, they have these other options that are available, you just got to use them. Nanoparticles, again, I think that's the future of many things, and you can make a hyperthermic type of nanoparticle, so you have light and heat, you get extra killing that way. You can use a paramagnetic nanoparticle, that way you could use MRI to actually direct the nanoparticle and the photosensitizer to your target. You could image it, then you could change and bring in light or heat and have a good treatment. You could use nanoparticles as carriers because if you recall when I started the lecture, there are a number of photosensitizers that just can't go through your body. They're either clumping or absorbed by your liver, so you could envelop those interesting photosensitizers in a nanoparticle, and that would help it get to where it needs to go. And the nanoparticle itself could be a light source. So you could use the drug that you have today and create a nanoparticle that is a light source, would get right into the tumor, and that'd be a very elegant way of doing PDT. One of the other things that we'll do in the future is we'll understand the reaction of PDT much better than we do today. Originally, it was a very, very intense light because you only got one treatment, so you did a lot of necrosis. Today, you can do much, much less intense light, prolonged light, so you could probably do things like vaccinations and local treatments with PDT. The organic LEDs might be implantable and dissolvable, so there's a whole lot of things that can happen. We've already seen that PDT, which started off as something to ablate tumors, we see it going into wound rejuvenation, wound healing, fluorescent phenomena to study how the body works, non-oncologic treatment of bacteria and viruses, dental disease. So there's a lot of basic science that we can build on for future directions. But ultimately, PDT will never really be as successful as we hope it would be until we get clinical trials to help optimize drug dose and light dose, and clinical trials to help optimize indications. There's a lot of off-label use, but it doesn't make it grow because people really like to see results, especially regulatory agencies. You show them the results. If they're good, you get approved. So the future direction, it's up to you guys to help PDT become more accepted as a treatment rather than something as last resort or a weird type of treatment that nobody really should do. That's it. Thank you.
So it was a very interesting talk. I have two questions. Firstly, you mentioned that Photofrin was not very painful, whereas ALA was much more painful. So I was just wondering what determines the pain, because all of them produce a singlet oxygen or some sort of ROS.
Yeah, so to me, it's probably not singlet oxygen that's causing the pain. It's probably where the drug is localizing more than anything else. Either that or nerve cells seem to be involved with some drugs and not Photofrin. So I'm not 100% sure why, but Photofrin never had a conscious patient say anything other than it's stinging toward the end of treatment. And stinging you can control with an ice bag. These other agents, you turn the light on and literally within 15 seconds they're starting to scream and squirm, and that doesn't help you make a good treatment. So Photofrin has got something special and to be discovered.
And my second question is, what's the singlet oxygen quantum yield for Photofrin at 400 versus at 630?
Yeah, so it's like it's 100 times better singlet oxygen producer to 1,000 times better singlet oxygen producer in blue light than it is to green and red light. So it's a quantum difference. And the reason that you would use blue light is because you could probably do a treatment in 30 or 40 seconds versus 30 minutes with the red light. So if you would be able to bring the light source really close to the tumor, that would be a very, very fast and elegant treatment than treating from a distance, which is what we do now, and suffer the consequences of a really long treatment. So 20 minutes when you're conscious and laying there, that's okay. 20 minutes when you're having a hard time breathing and quite ill, that's a different story.
Hello, I'd like to know the rate of successful treatment in PDT. Does it improve significantly better than the traditional conventional treatments?
Yeah, so there have been a few trials that have directly compared things. So in the skin, there have been a lot of trials, a lot of randomized trials. And PDT is generally equivalent in getting rid of the lesion, which can vary from 80 to 95%. So again, you have to pick the right patient for your treatment, but you still will get equivalent to surgery and whatnot. But in terms of cosmesis, PDT always comes out much better. In lung, for obstructing lesions, there was randomized trials using PDT versus cautery versus laser, and PDT gave equivalent opening of the lesion, but the length of time the lesion stayed open was double or triple with PDT. So again, PDT in the palliative situation when it's been compared has always done as well to open things up to get rid of your problem, but a much more prolonged period of quality of life. And in the early lesions, particularly in the skin where it's been compared, it's always done equivalently to the standard of care, but the cosmetic outcome and the healing and the disability to the patient has always been less. So PDT is really quite a good treatment. The problem is it's not always available. The problem is that a lot of times the first person who sees the patient will do the treatment they're most familiar with, and rather than thinking about what might be available for that individual.
Okay, thank you.
I have a hypothetical questions. For example, for oncologists like yourself, I would like to find out if you have some comments on what may hold people back to start a PDT trial, such as TOOCAT-based prostate PDT.
Yeah.
And you have a drug available, for example, you can have, the NIH protocol approved in, say a clinic setting. And also dosimetry supposedly you may, that probably is an area people worry about, but what else may potentially hold people back from starting such a trial?
Yeah, so the problem with PDT is that it's a little bit off the beaten path from what most surgeons might do or most oncologists would do. Radiation oncologists, we deal with some dosimetry, so it's not as foreign to us. But for a surgeon, they like something that will just cut or do the treatment. And you have things like microwave ablation, radiofrequency ablation, robots. You have a whole family. And the reality is that's something they're familiar with. Now you've got somebody's got to inject a drug, remember when the drug was injected, somebody's got to bring the laser, somebody's got to order the laser fiber. So if you don't have somebody like a physicist who will do all these things or make sure the checklist is done, it's a little bit out of the norm for most physicians and surgeons. And radiation oncologists don't like PDT because the dosimetry doesn't work as well and because it's competing directly with radiation. So you got this pretty bad sense that way. But the reality is if you were trained in PDT, you'd see how nice it was and how you could do additional things. And again, for any individual patient, having a choice of treatments might give them the best opportunity to get the best treatment. Just forcing them down one way or the other. And I would say in the United States, a major drawback is that there's a lot of infrastructure with robotic surgery suites and radiosurgery suites, and people who have spent $10, $20 million on that setup, they don't want somebody coming in on their ground. So in the United States, I think it's almost a lost cause. Complicating it too is the individuals who own the drugs have not made it easy to get the drug or the light source or the fibers. And at the same time, it's difficult to do that. It's easy to call up your supplier to get a radiofrequency toolkit, which is probably already in the hospital. So the United States is not going to be the leader in PDT other than theoretical aspects. There are always strong individuals and groups, but in terms of widespread use, that'll be a wave that has to be pushed back. Yet at places like Brazil and Asia, where it's wide open, you see it as a good treatment, and it's growing. And then when you have 50 or 100 dermatology clinics opening, that's the way you can push things forward too. So it's good.
Thanks.
Thank you, Professor.